Good morning, everyone. It's great to see you. It's always nice to have a full house. As you know, this task force has had to change its date. So many of our members today are virtual, but we still plan to have a very robust conversation. We are going to start shifting from presentations to where are we going, right? So it's an important part of the conversation that we're going to be having. And we are also considering, in this process of brainstorming about where do we go forward, we may be thinking about having smaller ad hoc meetings. We'll have to be very mindful of open meeting laws, so the entire task force would not be present at those ad hoc meetings. But what I would ask of you, those of you who are interested in participating, if you would please send to Mr. George, Andrew George, an email and let us know what your topic of interest might be and whether or not participation on a task force or an ad hoc committee might be something that you would be interested in. And then maybe what areas, specific areas, you think we need to make change or recommendations to the legislature. So you can participate by email, you can participate in person. We're just trying to figure out what does this process look like. We are hoping to have some sort of draft by the end of September. That would be our ultimate goal. So we have a lot of work to do between now and September to put those recommendations into some sort of draft form. So I just kind of want to give you the roadmap of what we're thinking at this moment. So now I will officially call the Legislative Task Force on Aging to order. It is after the hour of 9 a.m. We do have a quorum present in person and virtually. And I'm going to ask for approval of the February minutes. Does anyone have discussion to the minutes? Online, are there any discussions? Seeing no hands raised, the motion before us is to adopt the minutes from February 2024. Senator Housley, did you have a question?
Nope, no question.
Okay. All those in favor, please say aye. Aye. Any opposed? Hearing none, the motion is adopted. We will now move into public testimony. Do I see Lee? He's not here yet. Okay, we may come back to Leaf Green up. Renee Bymark is with us virtually.
Good morning.
Good morning,
Good morning. I want to thank the committee for the opportunity to speak today. My name is Renee Bymark. I'm the executive director of a home and community-based organization called Elder Circle. We are located in Grand Rapids, Minnesota. We serve all of Itasca County and parts of northern St. Louis County. Older adults living in rural areas have significant and unique and frequently unmet needs due to the limited access and availability of services in rural areas. They can experience deficits in nutrition, transportation, and a wide array of in-home services, which affects their ability to age in a place of their choice. The cost of these services are more costly in rural settings. We are geographically challenged when we're going from client to client in home. Sometimes that can be as much of an hour transportation in between. Lack of interest in direct care workers. That's been a struggle for us, is how do we attract more individuals into this field? How do we put more value on the work that they're providing for our older individual community members? And organizations such as ours are unable to provide high rates of pay, a lot of benefits due to the reimbursement rates of the elderly waiver. And also we offer free and reduced services for those people who do not qualify for assistance, but don't make enough money to be able to private pay their own services. Rural older adults who want to age in their homes often struggle to find professional in-home care workers, making them more likely to end up in a skilled nursing home. Rural older adults also have fewer options for housing and rental options than older adults who live in urban areas. We find that quite frequently if we're looking for a bed placement, that even those facilities are struggling with their workers and may have a whole wing that's closed down just because they cannot staff that area. Rural older adults also have more of a chance to be geographically isolated. Lack of accessible transportation being one of the biggest challenges for older adults. Healthcare systems too, getting quality healthcare in rural areas do not always have the specialists. Healthcare systems don't have the specialists. Older adults need to travel for their medical appointments. An example for us in our home and community-based organization, we provide medical transportation, and we do this throughout the whole state of Minnesota. We find that many of our older adults need to go out of our area for simple little appointments that we do not have those specialists, like a vitreoretinal clinic. That is one of the highest requested transportation we have. Older adults, of course, who are having sight issues do not want to have to drive, don't want to have to drive late at night, dusk, so it's prime time of day. We also have those challenges just with our northern Minnesota weather. We also find that sometimes the simplest little services that can be provided to an older adult can help them stay in their home as long as possible. An example would be snow plowing. If we can keep an older adult's driveway plowed and they can get their delivery of food, they can get their delivery of pharmacy, their in-home care worker can get there, an emergency service could get in. It could be that one simple little service that can help them remain in their home longer instead of placing into an assisted living or a nursing home. And these are probably the top issues that we see in our area. And I'm sure they're not unique to just northern Minnesota, but rural areas are definitely struggling and challenged with trying to offer quality services to older adults. And I really welcome questions or any additional conversations. And I thank you again for allowing me to be here today.
Thank you very much for your testimony. Members, did you have any questions? Any questions online? I really want to thank you for the testimony because you've highlighted many of the issues that we have heard about. Transportation, as you just said, is the number one issue, and we are hearing about that from all over the state. Whether you live in a suburban, exurban, or rural area, transportation seems to be one of those number one issues. And the suggestions that we are looking for are, what are the things that we can do that truly allow people to live in community and have that vibrancy of life for as long as they are fortunate to live. So I really want to thank you for that, and I would be happy to receive any suggestions, concrete suggestions that we could do or provide to the legislature. We will pass these along, but thank you so much for your testimony today. Next. Our next, has Leaf arrived? I don't see him yet. No, okay. We will come back to public testimony when our testifier does arrive. So we are going to move next to task force discussion, and I hope that it'll be a robust conversation. And I just wanted to remind everyone that the work of the task force is laid out in the legislation. And one of the really big things is we need to clearly define the problems that are before us and what are we trying to solve. So the questions that we have and we've made publicly available is we've heard many presentations on many topics involved with aging in Minnesota, and we still have more to hear. From what we've heard so far, what directions and opportunities should we start to consider when thinking of our recommendations to the legislature? And I'm going to open that up to the committee. Representative.
Hi. Hopefully you can hear me okay, committee. I apologize. I'm driving now on my way to St. Paul. Hopefully I'll be there within the hour.
Dr.
I
Gogler,
think it-
please proceed.
Yeah, can you hear me at all?
We can hear you loud and clear. Thank you.
Okay, good. Again, everyone, I apologize. I'm driving on my way to the meeting. I had a county visit yesterday in southern Minnesota, so I wasn't able to be there at 9 o'clock. One thing I think that would be helpful, Chair and committee members, is maybe we should start with, are we in agreement with the framing that Andrew had emailed out related to social determinants of health and those particular areas? I always like, I think, before diving into specific recommendations, is to ensure that we all agree that the framing of what will end up being this final report is something we all can agree on. And then from there, we could maybe then begin to highlight specific recommendations and other actions.
Members of the committee, do you have questions about the social determinants of health being our framework and promoting the work that we're doing? I keep going back and forth about this, Dr. Gogler. The social determinants of health we discussed in one of our very early meetings: economic stability, social and community environment, education access, healthcare access and quality, neighborhood and built environment. Those are the social determinants of health. And I think those should be our guiding factors. The question that I keep struggling with in my own mind is, how do we arrange a report, right? So when we're talking about transportation, do we talk about transportation and then look at those social determinants under that category? Or do we do it by category and then say how the social determinants should be defined?
I personally think thank you, Chair. I personally think you could do it either way. Certainly with transportation, I mean, that clearly seems to be an issue we are gravitating towards.
Dr. Gogler, Maureen has a question. Maureen, if you would like to unmute and ask your question or make your comment.
Thank you, Madam Chair, and good morning. I agree also with the necessity for a framework in terms of.
I think we should look at it in a more flexible way. In the case of transportation, I would argue it is a factor that can influence social determinants of health. Alternatively, there may be other issues that maybe fall more neatly under those categories. I think we should just allow ourselves that flexibility. That will end up creating a much more impactful report, in my opinion.
All right, Dr. Gogler, I'm going to ask you, I know you can't see what's happening right now because you're driving. If you can allow Maureen to make her comments, and then when you hear me state your name again, then I'll ask you to respond, all right? Maureen,
Okay.
All right, Maureen, if you would please go ahead with your comments.
Thank you, Madam Chair. I agree that the social determinants of health, according to the CDC, would make a framework, would form a framework on which we could hang our work. However, I want to make sure that we encompass some of the other work that has been done and is being done, not only in Minnesota, but around the United States. And so when I look at the 5 social determinants of health, I want to make sure that we are weaving within our sections of the report things like the Minnesota Age-Friendly Council multi-sector blueprint. They talk about connected communities, and they include emergency preparedness, and they also include optimized health and longevity. And then when I've been doing some research around the United States, I liked what the California Department of Aging had done on their master plan for aging. They focused on housing for all ages and stages. And then they really did a very broad brush on things like health, reimagined, inclusion, not isolation, caregiving that works. And then one that I think we really have to keep our eye on, and that is affording aging. And that is particularly important to me because I believe that our work is meant to focus not on those wealthy nor those who are eligible for public assistance programs, but rather the majority of us that we refer to as middle Minnesotans. Thank you, Madam Chair.
Thank you, Maureen, for those comments. And I think the pieces that you are mentioning with the age-friendly blueprint are just, I believe they're the different names for the same things. And so, you know, as we look at all of this work, to be understanding that many of these ideas are out there under different names and different, what do I want to say? Just names. I'll just say they're under different names, but they all are in fact based on these social determinants of health. So I do agree that this framework is really important, and I appreciate your saying that. I like the phrase that you just used, weaving in. I think that's really important, and to look at the work that is being done in the United States already. And when we are looking at aging, aging is across all economic groups. And we can't just focus on middle, we have to focus on all. That's the work of the legislature. So I do appreciate the fact, Maureen, that we can't ignore the middle, right? The middle cannot be ignored because they're there and they may not qualify for services. So how do we help them? But we also have to we have to focus on everyone. And I mean that most respectfully. Dr. Gogler, did you have comments?
Oh, yeah, thank you, Maureen. I agree 100% with Maureen in this regard. You know, we making sure and ensuring that we identify and where appropriate incorporate existing recommendations from initiatives and efforts that already have occurred or are occurring, both in the state and outside of it, is going to be very important. I mean, let's be blunt and honest with ourselves. I think we're going to come up with any new ideas. Maybe this has been something I've been reiterating throughout this task force. There is many of the recommendations already exist and are out there. I think for our purposes, it's important, one, to highlight those recommendations based on what we've been doing here in the task force that seem to most resonate and that we believe the legislature should focus on. And then two, coming up with a process to synthesize all that information effectively, which I understand is another issue, but maybe if time permits, we can talk about that a little bit too. So, I mean, those are my thoughts with how I, at least from my own personal standpoint, how I potentially envision something like this report looking like.
Thank you very much. Thank you very much, Dr. Gogler and Maureen. Is Representative Zalesnikar?
Good point. Thank you, Chair. From my perspective, when I look at the social determinants, I think I kind of look at it like a spoke on the wheel for us, where we have several spokes that are pieces, whether it's physical health, mental health, spiritual health, emotional health, social health, environmental health, financial health. And those 7 categories of our health, if you look at it as a spoke in a wheel, are all essential for the issues we've talked about through this task force on social programs, broadband, housing, transportation, modifying houses, and then workforce. But I think a framework with sort of what the CDC guideline is that we've worked under of the determinants of health is a framework. And then there's transportation falls under many of them. And then, you know, as do other issues of physical health, wellness, and client opportunity, or resident and citizen opportunities to gather together for exercise, get outside, get outdoors, you know, stay active. All those initiatives kind of pillar under it. And so I agree with the framework. I would suggest we take one that models all of those pieces, and then we prioritize the ones that seem to be the most impactful right now. My greatest concern after listening in this last, the times we've met is we clearly have a 40% increase of mental health. You know, we're coming out of a pandemic, so we're in a recovery period here. And so what you do in that situation sometimes, and that becomes the more prioritized issue, knowing that our society is dealing with that from birth to death of mental health that we didn't have before. And that is stressing our hospital systems at the ER. It's creating boarding situations to place people and then doing interventions early on to try to reach people where they're at. So to me, that's a starting point. And then coming to agreement on what we're going to do. There are many issues, and we won't solve them all, but I think having a framework and a roadmap on how this is going to move forward, I think will help us. Thank you.
Thank you, Representative Zalesnikar. Ms. Foley?
My question is, so we're going to list our top priorities. Are we creating a report that's going to be implementable or aspirational? Are we just going to make a report on lists and rank them 1, 2, 3? Or, you know, what is our ultimate goal?
I think that's a really critical question. I think it's an and question. I think there have to be some concrete recommendations that we say to the legislature, these are things we want you to implement now.
And are we going to list, you know, we've identified, you know, our top priorities. Are we going to list where we see gaps and such and list recommendations to fill those gaps? Or are we just, yeah.
So, Ms. Foley, I think your question is a really good one. We do need to identify the gaps.
Okay.
We absolutely need to identify the gaps. And then, in looking at those gaps, we as a task force can say, which of those gaps can we make recommendations in legislation that could be done right away? Or do we set out, do we recommend a system to try to address these gaps, right? Because as we know, we don't, on this task force, we don't have the power of the purse. And so we can make recommendations, and then the legislature will have to decide if they're going to fund it or move forward. So I think your question is a really good one, but I think that we can recommend no-cost solutions. I think we can recommend a roadmap going forward, or the need for the roadmap going forward. Further questions? Or further comments?
Yeah, this is Joe Gogler again. I think those are great points, Ms. Foley. What I would add to that, and again, at risk of sounding like a broken record, there are many reports that exist that have recommendations, and it's obviously vital that whatever recommendations we make, they're clear and actionable, at least from my opinion. I think added on to that, again, is going beyond recommendations and giving clear metrics for if this recommendation is implemented, how can we actually gauge whether it's successful or not? That to me has been missing in many, many white papers and recommendation reports of this ilk. And if we can at least move the needle in that regard, I think it gives us a more substantial report and framework to work off of. All of us, if not the legislature, then others of us who are in this space, so.
Thank you, Dr. Gogler. Are there more questions, any other comments online?
Can you hear me? This is Agatha from Grand Portage.
Yes, thank you, Agatha. Please proceed.
Renee Bymark's comments were right on point for rural areas, especially Grand Portage. If we were to take those social determinants and put them in prioritize them, what's good for a metropolitan area may not be the same for a rural area such as us. An example being, it's a 3-hour drive for a lot of our people to go, just for services for doctors. we have a challenge with housing up here, so getting workers to help with assisting elders so they can continue to live in their homes is a challenge. So I don't know how we can, there has to be a way that we can come into an agreement on what's important to a really rural area in relation to what's really important to a metropolitan area. But I think we're going in the right direction. I think all of those determining factors there are critical to everyone. Thank you.
Thank you, Agatha. And I think when we're looking at these recommendations, we can certainly discuss the varying needs so you are absolutely correct. The needs for transportation in the metro, again, whether it's the dense communities that have access to transit or the exurbs that do not have access to transit in the metro, those are very differing needs. And then as we move further and further out from, I'll just say the downtown Mississippi River area and going out east, west, north, and south, each of those regions will have very different needs. And we need to identify those. So under the topic of transportation, for example, the transportation needs that we may have in the metro, the suburbs, exurbs, and rural may be different, and those recommendations could be different as well. But we're hearing very clearly that transportation is an issue everywhere. But I think you're absolutely right, and I agree with you completely. Thank you. Senator
Madam
Housley.
Chair. Thank you, Madam Chair. I guess what I'm worried about is I've sat on so many task forces, and it gets disappointing after you spend all this time, put all this together, give our recommendations to the legislature, and it goes nowhere. It just sits there. And that's what I don't want to happen with this. And since we don't have the power of the purse, I think maybe if we could prioritize some policy issues that didn't cost anything and put those at the top of the list to get something done for sure this year. And then maybe after that, if we have some money, and I don't know if you know if they are going to allot us anything or if they're thinking about it, but if there is some money somewhere, what would be an absolute priority that we could actually get done this year? And then we can have there's so many in even just the 5 social determinants that Andrew sent out, and then what Representative Zalesnikar said with the different spokes of it could be a $5 billion package if we did our whole wish list. But if we could, for sure, when we come out of this, have something that we could actually implement this year to make sure that this task force wasn't a waste of everybody's time and it ends up as a paper on somebody's desk and goes nowhere. So those are my thoughts.
Thank you, Senator Housley, and I couldn't agree with you more. And I think that's why we were very careful to keep the task force small in size and to keep it in a really good bipartisan way. So we have bipartisan support in the Senate, we have bipartisan support in the House, and there is absolutely no reason why this committee cannot come out with good policy recommendations that could be implemented. And that work falls on us as legislators on the task force. So I agree with you completely, and there's good work for us to get done.
Thank you, Madam Chair.
So I'm just going to go back now and ask the question that Dr. Gogler started us out in. Do we have agreement among the task force that these social determinants of health should be our guiding direction? Maybe the easiest way for me to ask that is there any opposition to that being our guiding our guiding principles?
It's Joe Gogler again, Chair. I mean, it's, I guess, somewhat comical that I might raise a quasi-objection, but I agree with that. Just keeping in mind that with some degree of flexibility, I don't want us to feel like we're hemmed in either. You know, like a good example is transportation, obviously. It's not its own standalone social determinant of health, but it kind of cross-cuts so many of those. So just with that in mind, but other than that, obviously, I'm in agreement, so.
Well, I think we could classify it under two, whether it's community environment or neighborhood and built environment. So, and then Dr. Gogler, are you an economist on one hand and the other hand? I don't know.
No, I am not an economist. You could state that for the record, so.
All right, thank you. All right, so I believe we have agreement that the social determinants of health and aging, according to the CDC, will be kind of our guiding factors as we go forward about building a healthy state for aging in Minnesota. All those in favor of that, please say aye. Aye.
Aye.
Thank you, Dr. Gogler. So now I'll kind of move on to the next piece of that. So we've heard many experiences from members of the public have had in aging in Minnesota, and touching on these things like social programs, broadband equity, clearing of snow and ice, as we've just heard from Renee. What thoughts do we have about addressing these wide-ranging impacts on healthy aging and aging in community? So I'm asking for your thoughts about what we could do there. Or what other topics you might have. Members, do you have comments? Senator Morrison.
Thank you, Madam Chair. You know, this question, I think, brings up the complexity of our task and what we're trying to tackle here. I'm sure each of us has micro ideas about each of these and how we'd improve them in our own communities and on a broader scale. But I come back again and again in my own thoughts to, I think we need an agency. I really do. We have so many kind of small agencies in the government that are trying to tackle the different parts of the challenges of aging in community and aging healthfully. It's so big that I think we need a government agency to administer all of this. So I'd just like to go on record as I'm beginning to land on that recommendation.
And currently we have, so you're talking about a cabinet level agency? That was a yes, okay. All right, thank you so much. Representative Selesnikar.
Thank you, Madam Chair. And this is a very complicated issue, and when you look at the data, the issues are the same and then they're different. And the pieces that are different in greater Minnesota is just the transportation. And I serve on the EMS task force and then the Aging Service Task Force. So I come back to, after being at several meetings across the state on both topics and looking at how we age healthy, I keep coming back to the fact that 70% of our ambulance runs are non-emergency transportation. And that is a monumental expense. So for me, I am zeroed in on non-emergency transportation, and when I look at the data by county, we have the data of where our aging seniors are, and we also know the issues of transportation with people with disabilities. So the transportation needs are very different, and the models can be created, and they have been created. And I'm not going to get into funding mechanisms, but I think when you take care of transportation, the domino effect is the issues of boarding in the hospitals ends. The issues of social connections is improved because you're getting to your doctor's appointments, you're getting to your there's everything, whether it's getting food, just getting out for a drive improves your mental health. And so transportation, I think, is something that is imminently important right now and affecting people's lives and their health. And being home is great, but if you're isolated, it's not great. And if you have no socialization, it's not great. And without being able to have transportation, the mental health needs are only becoming exponential. So from my perspective of just listening for the last year, it's clear to me we have a non-emergency transportation, and we have a lot of opportunities that look different across the state, and partnerships that can happen between volunteers, paid staff, and those can get worked out in work groups. And what works in, Grand Portage and Roseau and Grand Marais and Proctor and Le Sueur and Winona and all these other communities is going to be different than maybe Minneapolis, St. Paul, and the suburbs, but it is still an essential service to get this non-emergency transportation taken care of. And Greater Minnesota has a different scenario to travel in, and we don't have the infrastructure, and nor will we. That's going to be a cost barrier, but there's other ways to do it, and I think that is one single topic. That's my perspective of what I come back to. We have county case managers, and we have systems in place for case managers. We have social service systems. We have case management. We have, in sitting on the task force, it's clear we have an IT issue. We don't have the infrastructure built within our state to assure that we can use data and track so that social workers and case managers and people that are doing child protection and trying to serve seniors and aging can do it efficiently, because the systems are 25 years old. The systems that report back to a state agency. So the communication is very broken, and that complicates services for people with disabilities and for people who are aging. And it just creates a fragmented system that becomes very costly. So from my perspective, having local control and having county control in the sense that they know the people. There is no way I, as an elected official, or anybody at a government agency is going to know what's happening in Grand Portage or southern Minnesota or east-west to the degree that the counties and the townships do in providing care at a local level. And so I'm a fan of that, and we have systems in place to strengthen, and I believe we need to go that route, to strengthen it to the best of our ability within a city, county, township, local level, at least for Greater Minnesota. That's how it works. And that's the model people are used to. And they're gathering in places right now because there aren't necessarily places, but they figured out. They're gathering at a bar, and they're doing painting and arts and crafts, and they're having church, and they're doing whatever is available in their community. People are very resourceful, but it's leading to positive health outcomes. And how do we measure it? When we don't have 70% ambulance runs that are non-emergency medical, because that's the statistic. That's an absolute metric to show success. So I think non-emergency transportation is a vital thing for many that have reached out to me. So thank you.
Thank you, Representative. Online, we have Maureen.
Thank you, Madam Chair, and thank you for this opportunity at this particular meeting for us to have these kinds of deeper dive discussions. There's been so much good that's already been said this morning. When I was thinking about Ms. Bymark's remarks earlier during her testimony, she demonstrated, I thought, a very broad knowledge of home and community-based service delivery in the rural. And if I had to, and I don't really want to, but if I had to narrow this down to maybe the top 3 things in terms of aging challenges, both rural and metro, I would narrow it down to transportation, always number 1 on the list. Housing and transportation go hand in hand. We heard a testimony a few meetings back where I took a quote that I've used some. Housing and transportation go together like peanut butter and jelly. So if I had to come up with a top 3, I would say it would be transportation, housing, and nutrition, because people simply have to eat, and some of the medical situations that we see developing come about as the result of lack of proper dietary and nutrition programs or even awareness. So that would be my top 3. And then I wanted to let you know, Task Force, that I did send out the discussion questions once I received them to our Minnesota Board on Aging members for some of their comments. And one of the comments that came back to me that I really, really took to heart was as follows. After listening to many of the presentations providing at task force meetings, it's apparent that those in the field of aging have been aware of the significant increase in the number of older adults and the impacts of that increase. Somehow, society has to start to, quote, get it, unquote. And so that leads me to a fourth point, which would be, what are we going to do about raising awareness? We are program rich, but the average person does not start looking at a program until a crisis has become a reality in their lives. Thanks, Madam Chair.
Thank you so much, Maureen, and I think the point that you raise is so important, that oftentimes our aging community in the United States as a whole is invisible. And there is so much silent suffering in our communities that raising awareness of aging and the needs of the aged are really important. And healthy aging begins, as Dr. Senator Morrison said, in utero or before. So making sure that we are looking at aging as just a natural progression of life, and making sure that in that natural progression of life, these social determinants that we're talking about are in place in all of our policies, and they are addressed. So right now we're having a robust conversation in the House and the Senate about housing and how do we address the housing shortage. And in sitting in those meetings, I said, you can't put up a triplex without an elevator. We have to think about the fastest growing population that we have, and that's our aging community. And so we have to make sure that each of those 3 units in a triplex are accessible. And it was like, well, we can't do that. It's too expensive. The rents will be too high. Well, we can't continue to build policy that is ignoring aging. So or disability. We have to look at these policies from the beginning. So if that's what zoning looks like, then we need to make sure that aging is part of that process. And that's the type of work that I want us to bring forward in our recommendations. That no matter what policy, if we're addressing nutrition and how we provide nutrition, it starts early so that we keep people healthy, so that as they move into aging, they're healthy already. And then how do we get that nutrition to them when they're no longer able to drive or get out for themselves? It is a continuum. It doesn't start at 55, it doesn't start at 65. It's a continuum. So I think that's when Dr. Morrison talked about we need a agency, that's kind of the focus. How do we keep aging front and center of all of our conversations in this state, and that our seniors are no longer invisible? So thank you, Maureen, for your comments. I greatly appreciate them. I see that our testifier from the public has arrived. If you would like to come forward and present your public testimony, I would appreciate it. When you're ready, if you'll state your name for the record and begin your public testimony.
My name is Leif Grena, and I apologize. For some reason, I thought this meeting was at 10 again. So I appreciate the opportunity to go forward. Again, my name is Leif Grena. I'm the president of the Minneapolis Regional Retirees Council, a constituent organization of the Minneapolis Regional Labor Federation. We are comprised of some 18 local and regional union retiree organizations. And we join today with Elder Voices family advocates in calling for the task force to work toward creating a Minnesota Department of Community Aging. Why community aging? The majority of elders strongly desire to age in their homes and communities. This desire coincidentally makes good sense from an economic perspective, as well as for our physical, mental, and emotional health as we age. Why a department? We all know that our population is rapidly aging, and this has enormous implications for housing, healthcare, transportation, and recreation. Although the state has initiated and supported a number of policies and programs to support our aging population, these are scattered among a number of departments, boards, and agencies. We are in need of coordination and integration of resources into a strategic plan. As I stated a moment ago, aging in place as long as possible is cost-effective in relation to institutionalization, but we do not have an aging in community in place as a policy objective. We know that ageism, an issue the task force needs to address, is the last form of bias and discrimination that remains socially and politically acceptable. This needs to change, and we need leadership to move this change. Ageism costs the U.S. economy an estimated $850 billion. The healthcare cost of ageism, according to one study, is estimated at $63 billion. Our aging population is a vital asset to our communities and our state. Elders in Minnesota are the largest resource for child care, and we are a huge volunteer workforce, providing folks engaged in a variety of valuable work, from feeding the hungry to manning our polling places. We need a department because we need to develop strategies, policies, and programs to coordinate investment in our people as we age. And why not create a department? One argument will be that Minnesota does not need another bureaucracy. But the truth is, we already have one. It is scattered now among several different departments, boards, and bureaus. It is in need of coordination and focus. We can anticipate the argument that we may not afford it, but we are already spending a large sum of money in a response to the challenges we face, spending that is not coordinated and strategic and does not address the underlying challenge of ageism. It is clear to our council that Minnesota will benefit greatly from a department charged with developing and implementing strategies, programs, and policies to ensure investment and a strong foundation for our future. We urge you to remember, we are all aging. This is not about a population in need. It is about our commitment and investment in the future of all Minnesotans. Thank you.
Thank you very much. Awesome. What? Okay. Normally, we would say no clapping, but could I ask the page to come forward for just a moment? Yeah. Okay. Could you come for just a moment? Will you get this package for me? Would you get that folder and bring it to me, please? Thank you. Thank you very much. I appreciate it. All right. Thank you very much. I know we've kind of gone a little bit out of order. Wait, Dr. Gogler, did you have another comment that you wanted to make?
Oh, no, actually, none. Not at this time, anyway.
Okay, perfect. Thank you. Senator Morrison.
Thank you, Madam Chair, and thank you to the testifier for saying much more eloquently what I think I was trying to say as well. Just, you know, and it is not to minimize all of the important work that so many groups, task force, agencies, boards are doing and have done. But this idea of needing a coordinated approach under one guiding entity, I think is really important. And when we think about just the straight demographics of where we are and where we're going, this is a significant portion of Minnesota's population. I think that's where we got to land.
Thank you very much, Senator Morrison. And I think I'm just going to try to wrap up this piece for now because we're going to go into our presentations, and I've promised to be on time today. So it is identifying what's missing in our current structures. And perhaps we do need an agency to focus on this, so I appreciate the testimony as well. And it is making sure that the people of Minnesota understand that there are agencies and organizations, and understanding how that work is being done, and then building that trust for making sure that people know that they're being represented and that there is someone advocating and looking out for them as well through the aging process. And then as we go forward in our work, we have to think about the gaps, the structure, and the funding, right? All of those things have to be considered. And I think we will close this discussion for now and bring forward our presentations for the day. And with that, we'll begin with the Trellis presentation. If Ms. Simpson will come forward.
Put this in the presentation mode, or how do you, should I put this in the presentation mode? How do you want to? Just move it. Oh, okay. How do I move the slides? Down here, yeah. Okay, gotcha.
Welcome, Ms. Simpson and Mr. Cullen. When you are ready, if you would state your name for the record and begin your testimony.
Yes, thank you. Thank you, Chair Claiborne and members of the task force. My name is Dawn Simonson, and I'm the president and CEO of Trellis. We're a community organization that provides services, connections, and innovations to help people as they age. And our core programs include those provided through our designation as an area agency on aging. I'm joined today by my colleague Mark Cullen, who leads innovation and development of strategic partnerships at Initiative here at Trellis, and he will help me answer questions. We hope you have some. We're here to share our vision for improving access to services that help people to age well while creating efficiencies and cost savings to the state. Our innovative model, the Juniper Community Care Hub, serves people across Minnesota. Its structure enables services to operate at scale and in partnership with healthcare providers and payers. We operate with a double bottom line philosophy. The Juniper network of community-based providers helps older adults thrive at home and is an untapped resource to aid in curbing the projected costs of health and long-term care for our state. Every speaker today has articulated the growing recognition that social supports such as food, assisted transportation, and isolation reduction can impact an individual's health, and we have to understand related healthcare spending. Now, historically, health and social services have operated as two largely independent sectors without a concerted effort to use social services as a tool to improve health and wellness and drive down the overall cost of care. Minnesota is uniquely positioned to move the hub model to a scale that will have real impact on the state budget. We're so lucky. We have all the ingredients: world-class health systems, thoughtful healthcare payers, innovative government, a strong network of nonprofit organizations spread throughout our state and supported by one of the country's best philanthropic and volunteer environments. It's time to leverage these important assets. Now, Juniper is one of the first established networks of community-based organizations in the United States, operating to integrate social care with healthcare. We operate a community care hub framework that is central to how the Centers for Medicare and Medicaid Services, the Centers for Disease Control and Prevention, and the Administration for Community Living think about integrating healthcare and social care. Now, our roots are in the aging network. We were fortunate to begin this work in 2016 through deep partnerships with organizations across Minnesota that maintain today. Their collaboration has helped us gain scale to provide healthy aging programs across the entire state within a few years. Now, the Juniper Community Care Hub leverages and builds upon Trellis's core competencies and works through social service organizations trusted by local community members. Together with the local boots on the ground, the Juniper Hub tailors services to meet local needs. We've heard that over and over again today, how important that is, especially in rural communities. We know it's also important for diverse people. Put simply, Juniper is a collection of community-based organizations from across Minnesota that operate collaboratively to support residents in all 87 counties in our state. These organizations share administrative infrastructure to enable lower service delivery costs while gathering data to ensure services produce strong outcomes for our communities. The result is a compelling return on investment that totals millions of dollars each year. Our opportunity now is to expand the kinds of services that are available through this structure and bring more support to older Minnesotans and potentially others. Today, chronic disease drives 86% of all healthcare costs. Now, we recognize that dementia is also an enormous cost driver, as the study on the screen indicates. Most health economists expect these rates to continue as medical treatments advance. In your previous meetings, the Department of Health provided excellent details about the impact of chronic disease. We'll highlight just a few in the context of our proposed solution. As an example, and of particular concern in Minnesota, is the frequency and cost of falls. Now, falls start as minor events, often explained away as clumsiness. As they grow in frequency, we start to see injuries and even deaths. The costs of falling are particularly shocking. This slide shows that the Department of Health estimated the cost to Minnesota from falls to be $700 million in just 1 year, and that year was 2014. The report published in 2023. With recent inflation in healthcare and throughout our economy, we know that falls today are much likely more expensive. Now, we know from the literature and our personal experience among ourselves and our families that one fall is predictive of more falls. As these falls increase and injuries occur, people often end up for treatment or stays in healthcare settings, hospitals, transitional care, and eventually nursing homes. These events have enormous consequences for Minnesota families and the state budget. Earlier this year, we released a white paper on our fall prevention programs. We focused on fall prevention because measuring the instance of a fall and its resulting cost is easier than measuring the costs of chronic disease, which are multi-causal and progressive in nature. Now, the findings in our study demonstrate what is possible through our hub solution, and it may indicate savings achieved through additional social care services. Functional decline is a significant issue within the older adult population. It's been estimated that 16% of Medicare patients are frail. While this represents a relatively small proportion of the entire population, the same data suggests that an additional 47.2% may be classified as pre-frail. Keep in mind, we have 1 million older adults in Minnesota, 65 plus, most of them in our Medicare program. Additionally, physical frailty may be linked to cognitive decline, which can also increase fall risk. Among community-dwelling adults considered to be at high risk of falls, research indicates that those with cognitive impairment were 2.6 times more likely to have a fall than those with healthy cognition. For these reasons, it's critical to acknowledge and assess physical decline early and take steps to reduce or avoid decline in physical function in those who are currently fully functioning. Now, we know this task force is tracking closely on these issues because of the outsized impact to state budgets forecasted for the next several years. On this slide, you'll see a screenshot from the Minnesota Department of Human Services Own Your Future report. We were so excited when this report was released. Now we can link these public health facts to projected costs in the state budget. The population of most concern are individuals in the red box, people with too much income and assets to qualify for Medicaid, federal and state paid Medicaid, but not enough to pay for expensive long-term care costs out of their own pockets for any length of time. As these individuals spend down their assets, they do become eligible for Medicaid, but often by the time that happens, their care has become very difficult to manage and has disrupted their lives and families. As you see from the slide, these costs are expected to grow by 70% over 12 years at an annual increase at 4.5% each year, totaling $1.5 billion. We must take action to stem this tide. The good news is that upstream remedies that address the projected growth in cost of care can help people live healthier lives as older adults. The report specifically names increasing access to community-based services and supports that are initiated early is a key opportunity for Minnesota. Our solution is to make social care, fall prevention, diabetes prevention and management, assisted transportation or caregiver support services more accessible by utilizing the existing assets of our state to integrate healthcare and social care. We can do this by tapping community-based organizations throughout the state, organizations like Elder Circle, they're a longstanding partner of ours, to deliver services in partnership with local healthcare providers and insurers, just as we do in Juniper today. Since 2017, we've served more than 30,000 Minnesotans from all across our state. Over time, we've focused on health equity, ensuring that services are accessible to many distinct populations. For example, since we began, half of the people served live in rural communities. Last year, 15% were from communities of color, and we offered healthy aging services in 7 languages. Our focus on improving access to care with an equity lens is core to Trellis values. In order to enable contracting, payments for services, and data exchange, and to continue improving access to care, we need to consolidate administrative functions and risk to enable small, community-based organizations to serve Minnesotans in a healthcare context. Juniper was one of the country's first of 58 community care hubs operating centralized functions and is often referenced as a model for newer hubs. Consolidating these functions has helped us bring nearly $3 million to community organizations that would not have otherwise been available to support service delivery. This is new money rather than a rechanneling of existing funding. If we agree that home and community-based services, social care can improve health outcomes and lower costs for certain populations experiencing certain health needs, then we need to integrate social care at scale and begin to measure value. We can do this because it's the right thing to do, and we can do it because it serves the public and private sector's financial interests. Again, the double bottom line. In the past few years, the Centers for Medicare and Medicaid Services has increasingly encouraged and enabled healthcare providers and health insurers to integrate more social services. Of importance, CMS has made efforts to establish payment pathways to Medicare for social services. This is a game changer. The slide demonstrates that a care hub like Juniper can facilitate the secure flow of data, support clinical outcomes, and enable payment for services. We believe this structure can reduce the state's financial obligations over time by shifting costs to healthcare risk-bearing entities. Again, if social services are delivered at the right time, in the right mix, to a target population experiencing a health episode or condition, there should be a positive return on the investment in the social services. Doing this well will enable new data insights through medical coding of social care that can help risk bearers, such as the state of Minnesota or health insurers, gain better insight into the needs of people that are working hard to manage their health and well-being. These insights should allow us to improve innovation in service development and delivery, while also targeting services to the people and places where they are most needed. This structure would also allow Minnesota to leverage its public health investments for lower future costs, while enabling healthcare organizations to meet new requirements from accrediting bodies like the Joint Commission and the National Committee for Quality Assurance. Finally, we can make nonprofit community-based organizations more efficient. This efficiency is important because dollars available for social services are declining. Today, less than half of Americans contribute to charitable causes. Compare that to 20 years ago when 2/3 of Americans donated to charitable causes. COVID-related stimulus dollars are fading into the rearview mirror this year, 2024. We need new sources of revenue to sustain our community organizations in Minnesota to deliver services that support older adults. Beyond driving efficiency and of utmost importance, we and our partners can produce life-changing outcomes. The data on this slide demonstrate that people who receive support through the Juniper Network have taken meaningful action to improve their health and well-being. They are improving their physical activity and mental health, eating healthier, and socializing more. If Minnesota implements community care hubs at scale, we are confident that the result will translate into significant cost savings. Here we highlight fall prevention as proof of concept that demonstrates that remarkable savings are possible. Imagine what services like transportation, chore, and home modifications could do if properly targeted. In 2023, 1,974 Minnesotans completed Juniper prevention programs. Savings attributed to those participants in fall prevention totaled $8.8 million. After factoring in the cost to operate Juniper last year, those savings translated into a 283% return on investment in 1 year. ROI for socially isolated people is even more compelling, totaling 1,576% due to the high health risks associated with this group. We think these outcomes, and they are very conservative, are possible because prevention simply doesn't cost that much. And healthcare services such as hospitalization, emergency room, and rehab stays are very expensive. If we can focus on preventative services and upstream social care, we can begin to make a dent in the looming costs we discussed a moment ago. When we share our vision for Juniper, people often think about their own lives. Perhaps you are thinking about your own experiences now or the experiences of a parent, spouse, neighbor, or family member. We have never been better positioned to support our loved ones through the aging journey. From the day a health condition first comes to the surface to the very day we say our final goodbyes. By making services more available and segmenting them so that they are delivered when most needed, we can all live our final years with a higher quality of life and preserve resources for future generations. I conclude by asking your consideration of 3 points. The first is that to better address the health needs of older adults, we must address their concurrent social needs. The community care hub model implemented at scale can be a solution for this purpose. Second, the Own Your Future demographic analysis, actuarial study, and broad-based stakeholder recommendations should be thoroughly evaluated to bring together an implementation package for consideration by the legislature in 2025. Third, it is essential to make older adults and aging-related policy a priority of state government. Minnesota can and should lead on this front. Establishing a cabinet-level position for aging in the governor's office would spur innovation and help ensure that issues of older adults and family caregivers are addressed systemically, with authority, and in collaboration with other leaders in state government. Thank you for hearing us today. We appreciate the momentum that the task force is helping to create on issues of aging and thriving in community, and we're happy to answer your questions.
Thank you very much for your testimony. And I really appreciate the time that you took to come and talk to me about this. So I appreciate that. Dr. Gogler, did you have a question?
Thank you so much. Thank you, Trellis, and for all the wonderful work you've done and to provide, kind of really show what's possible in terms of innovation, which certainly the Trellis Area Agency on Aging and all of its initiatives have shown. And, you know, I really wanted to gravitate towards the last point, which is, I think, the point we left off on in the first part of the discussion, which I'll be blunt. Initially, when I joined this task force, I did have some reluctance in thinking of another cabinet level position for all the reasons already described related to aging. But as I've been hearing more, not just from organizations in Minnesota, but then also from older people themselves. I was just in Jackson County yesterday giving some dementia education presentations. It's becoming more evident to me, for all the reasons you mentioned, Chair Cleavorn, what you had just stated. We probably need to think very seriously about how we can affect better coordination of aging across all of the existing units in state government. Now, whether it's a new cabinet level position, from my understanding, isn't there a cabinet for kids in Minnesota or something? I mean,
Division of Child, Youth,
Is that what
and
it's called? Okay,
Families.
someone called it Cabinet for Kids. I'm sorry, I didn't know what the title was.
There is a children's cabinet.
Thank you, that's better, okay. But I mean, at the very least, initiatives like that, but at the same time, thinking very seriously about this coordination need, I'm becoming more of a supporter of it, so.
And I think it might be helpful to the public because we mentioned Trellis, right? The general public may not know what Trellis is. So maybe you might just want to say the work of Trellis just briefly.
Chair Cleaver and members, happy to do that. So Trellis is a nonprofit organization. We do our work through two organizations, two nonprofits that are related to each other. And we are designated as an area agency on aging, and in that work, our core programs, we administer the Federal Older Americans Act funding program, so we support meals, rides, chore, caregiver support, but those federal dollars are extremely limited and they don't grow. We're also the state's partner to provide senior linkage line services. We though leverage those very core programs and that area agency on aging designation to be certain that we are adding more value to our work and that we are working to meet the needs of older adults and family caregivers. We have done that through work in helping to build dementia-friendly communities and in our work to build our Juniper initiative. And again, the Juniper initiative is really our vision for how older adults and family caregivers in Minnesota can receive the services that they need by providing an influx of resources and other supports that will give us an ability in our state to expand services. Without mechanisms like this, we don't see other paths forward that will have a positive budget impact for the state of Minnesota. We think because of the growing demographic, our state demographer, Susan Brower, the blink of an eye, our 75-plus population is here. People start to need services when they reach this age. We have got to think about growing services and supports, getting upstream, focusing on prevention in a way that helps people thrive as they age, but also is laser focused on curbing the cost of care.
Thank you very much. I appreciate that. Representative Zalesnikar, and then we are going to move on quickly to our next presentation after your question. Please go ahead.
Thank you, Madam Chair, and thank you for your presentation today. On the piece of the falls that you were talking about, I think the issue of the falls studies is important. And just in my career of the last 40 years of caring for seniors, it comes down to so many of them even not wanting to stay hydrated because then you have to, they don't want to have to take the chance of getting up to go to the restroom. And so it's, and many times in my experience, the ambulance run for an aging senior was a bladder infection from not having fluids. And so just basic interventions of making sure a urine sample's taken when there's a change of condition to make sure seniors don't have that because it affects behaviors and it affects fall status and so many things that need to happen. So, but the hydration and the nutrition are tied so much together, and there's reasons for both. Appetite changes, and people's teeth don't fit the same. They have dental issues, and medications interact differently. So I think all the work that you're doing is very important. I think that the more we can do, I love the hubs, I love the community connections. I think that's the heart of our communities in Minnesota. And they might look different, but I'm just a big proponent of bringing that knowledge local because we have systems in place with the health programs, the medical models in our community with clinics, physicians, hospitals, and community centers and education models that we have through community ed. And strengthening that with the models that you're doing, I think is the route we have to consider because we have probably 20 commissions right now, or cabinet levels. And so growing that is sure, in an organizational structure, we could have an aging department, but we have Department of Human Services, we have many departments right now, and with the change of moving out children, there's going to be more opportunity to care for this piece. So my position is, let's fix what's broken right now. Let's make sure that we have the right integration with broadband in Greater Minnesota to assure social service departments can do what they need to do to serve the people we have. Because if we don't fix the horse first, these carts are just secondary. And so I'm not against an agency thing. I just think it's not going to solve the issue. It's not going to solve the issue on the end game, to the points made before, that I don't want to see this just be a task force without having the state see positive impact for Greater Minnesota, for the suburbs, and Minneapolis, St. Paul. And the reality is, of listening in committee for this last year, we have technology that is 25 years behind. And so that is not efficient, it's not effective, and if anybody's ever tried to fill out medical assistance applications at any level, you can't even save the data. You lose it, it's gone, there's no ability to cut and paste. It's 100-page forms for families, and you're mailing in and faxing, and if somebody doesn't receive it, you're doing it all over again. So we need to get efficient and effective before just building another thing. And so I appreciate all the things that you're saying. They're spot on. It's just, what is the best strategy recommendation as we move forward? And I appreciate it, but I love the hubs and the care coordinators, and whatever name it is, the intention of what's happening is back in the community. And I think that's what lends itself to the best success. So thank you for all your initiatives.
And Representative Selesnikar, I'm just going to take a moment of personal privilege and have a little fun. So in the state government bill last year, we made incredible investments in our IT so that we can repair many of those things that you just say are a problem. So I'll just encourage you to go back and read that, and if we need to make more investments elsewhere, okay, I'll encourage you to co-author that bill with me. All right. Thank you so much for your presentation. We are going to move on to senior social isolation and Linda Camp. Thank you.
Is that the slide set?
Thank you, Ms. Camp. When you're ready, if you'll state your name for the record and begin your testimony.
Thank you for the opportunity to be here today. My name is Linda Camp. I live in St. Paul, and I identify myself as sort of an independent researcher, consultant, writer. And just to let you know, the work that I am talking about today is some things I have been doing on a pro bono basis for about the last 9 years. So today I'm going to be talking about solos. And let's see if I get my finger on the right key. Oop. It's not advancing. There it is. Okay, here we go. You heard in the introduction the word isolation and whatever. What I'm trying to do here today is offer you a different framework, because when the term solo is used, there are many different interpretations and different language descriptors used, and these are some of the things that automatically come to mind for a number of people when they hear that. But what I'd like to do today is offer you a broader framework and talk about why this broader framework is really important for Minnesota. Oh, gosh, find the right key here.
Is it advancing? We have technical help.
Yeah. This one over here? Is this what I'm doing? There we go. There we go. All righty. A different computer. In 2018, I was able to work with the Minnesota Citizens League and the Minnesota Elder Justice, and we formed a partnership and went to the Bush Foundation and got a Community Innovations Grant to do a foundational study on the whole emerging issue of solo older adults. And it was a very interesting and effective interdisciplinary task force. And we spent a lot of time talking about what we were going to call this demographic group that we were trying to focus on and how to describe it. And what we basically came up with was this definition, that we should not be focusing exclusively on sort of the demographic characteristics, people who don't have children or have no partners, that the overarching concept and thing that all solos have in common is the fact that these are individuals who basically are functioning without that traditional family support system. And that may happen either by their own choice or by circumstances that they're in this situation. And we thought it was really important to explore the concept of people who are, quote, functionally solo, meaning they might look like they have a support system, but when they get out and they need help, they need support, they need care, that support system is really not there. Oh, gosh, just not used to this keyboard. There we go. So here are some of the what we call risk factors that might contribute to people fitting into this solo category. And the top group, and these are just some examples of what most people are thinking about. And if you've seen some articles in the press related to solos, you probably see the articles that are focusing on people who don't have children. And there's a lot of, or maybe don't have a partner. There are a lot of those people, and we hear a lot about the fact that there are more folks out that don't have children. But that's not the only reason why people might lack this support system. There's also relational issues, and this is another one that you do hear something about. People who are estranged from their family, people whose children live far away and they're not in a situation where they could actually help somebody. So there's lots of relational things. And then also people who by choice just simply want to live alone and do not want to be in a family type relationship. The third category I have here are things that we think about less often, that there's a number of behavioral reasons why people might be characterized as solo. And think about some of the people that you know that are very independent and refuse to ask for help. People who tend to be reclusive. There may be people with just personality kind of characteristics that don't lend them to developing good relationships. So there are behavioral reasons why people might wind up being a solo. The last one in this behavioral category that I wanted to highlight, because it's out there, it's growing, and people don't recognize it very much. There are now a lot of people who have children, who have very good relationships with their children or their other family members, and are saying, we don't want our children involved. And I have found some data from University of Chicago and a couple of other studies now where people are making that kind of comment. They just simply either don't want to burden their children, they don't think their children are capable of providing the support they need. There's a number of reasons. And I can tell you from anecdotal experiences when I've been and talking with groups of solos, I would say probably about half of the people in the room raise their hand and say, I don't want my kids involved. So it's a whole thing that is emerging that we don't even think about. So there's a lot of folks out there who are functionally solo, who probably on the surface do not look like they're solo. So how many solos are there? Hard to come up with a number. We can count people who live alone and who have no children. I mean, the census provides a lot of very good data for us on those things. But it's much harder to count people who are stubborn and don't want to ask for help, or some of those behavioral characteristics. We don't have a very good way of tracking them down. So what I've done is go through the research and try to take a look at some of the individual pieces of these different categories and find any research that seemed relevant. And so these are some of the pieces that I have found out. For example, a Cornell University study of about 2 years ago came up with a number of 27% of adults have some kind of estrangement from family members, which is a pretty high number. So when you take a look at the cumulative impact of all these little pieces, my personal estimate right now is that there's probably something close to 30% of the older adult population that are in this solo situation and would meet that definition. Here's a Minnesota example. I just used some of the census data. It's only in one category, but about a month ago, I had the opportunity to have some conversations and do a presentation with representatives of Minnesota's counties where there's some age-friendly activity going on. So I took a look at all those counties, and the census divides the data into when you're looking at households, there's family households and there are non-family households. So I looked at the non-family households, and that's where the people who are living alone shows up. So these are the age-friendly counties, and it shows you the percentage of non-family households where there's just one person in the household. And it's divided it up into male head of household, female head of household. So as you can see, there's a lot of women throughout the state of Minnesota who are living alone, older women who are living alone. And the thing that's kind of interesting that doesn't pop out quite as clearly here, but if you took this up to 100%, so the folks that are not living alone and that where the bars end, when people are living in a non-family household, they prefer to live alone. There's only a relatively small segment of people that are actually living with somebody who is not related to them. So there's a lot of theories about, Golden Girl homes and things like that. And it's interesting that people are not choosing that. They may prefer to live alone, but the other thing that may be a factor here is that there just may not be as many options for people in various parts of the state for how they live and what their options are for living with other people. So why do we care about solos? And we've talked about it today. Why do we care about older adults? We've really talked about we want people to thrive and be in the driver's seat of their own lives. And so care and support for the population is kind of what the conversation has been here today, and that's what's important. So it's hard to find anybody who's done really, really solid work on, who's providing the care and support now on a global, kind of a national basis. But this is the most recent stuff that I could find. And right now, the data shows that about 64% of care is being provided by family members or non-paid support, but most of that is family members. Only about 14% is paid for exclusively, private pay, and then there's another 22% where there's the care and support is partially paid and then partially done by non-paid. So that could be family or could be friends or neighbors or whatever. But as you can see, most of the support is being provided by family. Not that many people are paying 100% for the care and support that they receive. The interesting thing that I did not put up here, but when I looked at there was this same analysis that was available back in 2015, the family support chunk of the pie has shrunk by a few percentage points, and the other two categories have increased. So family support is declining, and for a number of reasons. And obviously, if there are fewer people that are getting married and raising families, then that support network is gone. So let's talk a little bit about what care and support means. What are we talking about? And this pie here, what I did to take a look at what constitutes care and support, I looked at some research by ARP. Every few years, ARP does an update on family caregiving, and it has a whole section in there about how these family caregivers are spending their time. I also looked at the Bureau of Labor Statistics does analysis of time use, and they have a whole category on family caregivers, or caregivers, period. And again, what are they doing? So there were 4 big chunks of activity that showed up in both of those studies. The activities of daily living on the right-hand side, and that medical support. Those are things that we're real familiar with, and we've already heard some of that, some of those kinds of services being talked about today. But the other things that showed up that are not as probably as obvious or thought about are financial tasks, and there is some of that, people helping with bills and that sort of thing. The big one that is getting overlooked is this last one, which I'm labeling decisional support. And you think about it, that when you're locating services for people and whatever, there's a lot of kind of invisible support where the family member or somebody is helping out to coordinate, to do research, to evaluate what's going on, to, it's help somebody make a decision about what they want to do. So I call these kind of the glue services, the things that kind of hold it all together. And what I also find is that there are far more resources available on the right-hand side of the pie chart here for those activities of daily living and the kind of medical management stuff. Far more resources that are out there and being funded on that pie half of the chart. But on the other half, the financial tasks and the decisional support are not as available. And so you think about somebody trying to put together the support system for themselves. Who's helping them in this whole decisional category? If they're trying to put together a plan and identify services and whatever, they don't have that sort of glue person to kind of help them keep it all together, or glue people. So for solos, actually, they probably can have some success in locating this kind of services and support on the right-hand side. Much, much different on the left side of the chart. That those decisional and financial things are just less available, but very much needed by solos.
Ms. Camp, you have provided us a great deal of information, and I would like also to make the public aware. This is your book as well, correct?
Right. Yes, there are three handouts. You have the report from the task force that I mentioned, the Bush Task Force.
Yes.
There's also an article on
the backup plan.
The backup plan, which I'll just reference briefly. And then there is a white paper that I did called Why Solos Matter to Minnesota. I did that for some of the staff in Human Services who are working on the update of their plan for the Older American Act funding.
Because our time is limited, and we still have one more presentation to go, I'm wondering, at the very beginning of today, I mentioned the fact that we might want to do ad hoc committees with maybe just a couple of our task force members present, and then bringing this group together to do these smaller and more in deep dive conversations. And I'm wondering if you would be, if I reach out to you in the future, if you would be willing to work with us in that task, because the issues that you're raising here are really critical, and we don't have the time to give it justice today.
Sure, I'd be happy to. If you want to take another minute, I do have some recommendations and some things here.
If we could go quickly to those, that would be wonderful.
Okay, so this last one, I just wanted to tell you a little bit about some of the things that are going on in Minnesota, most of which, are things I've been working on. But you should know that the activity that's going on related to solos in the rest of the country mostly is focusing on sort of one-on-one counseling and helping people plan. what I've been trying to do here in Minnesota is focus on the systems issues and sort of the global things that make it all work, because a lot of the problems that we've talked about today cannot be solved by an individual. They have to be solved, like transportation, some of those other things have to be charted at a larger level. So the Citizens League Task Force was our foundational work. I've done so far 34 presentations to organizations to help everybody learn about solos. Backup plan model, which is a tool for helping solos form peer support groups. We also, as I say, I worked with the task force, the group of staff that are, last year were updating the master plan for the Older American Act funding. We are the first and only state to reference solos in that plan. So that's a win for our state, and I hope we can start building on it. So just a couple of the recommendations. I think this isn't, we talked about older adults being invisible. Older solo adults are even less visible because we've relied so long on family. So the more we can do to specifically target and mention and reference solos in the policies and practices and whatever we're doing, the planning, that's really important. And we should give priority to the resource gaps, as I mentioned, some of those on that left-hand side of the bar chart when we're using our funding, Minnesota funding, if we could start focusing on some of those pieces that are particularly relevant to solos. One of the other things, solos particularly need to be addressed when we're looking at workforce issues. So again, some of those on the left side of that pie chart, specifically looking at some of those gaps in resources. The other piece I think would be really easy to do, we should start trying to document the number of people who might fall into this solo category. And I think you can do that without a big amount of research. Look at the places where we're capturing data now and just add an additional question or two that would help say, well, a little box that says this person, seems to meet the test of a solo. So it would help us to get a better picture of how many people really are in this situation. So I will yield the floor, but I do appreciate the opportunity and very happy to work with you any way I can in the future.
The topic that you were bringing forward is critical. And the idea of solo by choice, I keep hearing a constituent story of, my son is always in my business. I don't want my son in my business. The fierce independence that is in our communities is really important to recognize. And the intentionality of agency and including agency in our decision-making, I think is important because often older adults are looked at as not capable of agency, and they are. And I think the conversation that you're raising is critical. Dr. Gogler, did you want to say something? And then we'll move on.
Thank you. Thank you, Ms. Camp, for coming. I remember when you first showed me this report when it came out back in 2019, so I really appreciate it. And, it reminds me something that Representative Zelenskar mentioned earlier about the mental health issues. We know living alone is linked for older people with a number of adverse health outcomes. It includes dementia, expedited mortality, et cetera. But, the other thing to think about, digging deeper, living alone is kind of a proxy, but doesn't totally capture what I think is the really important driving factors. Not necessarily living alone, but being lonely. They're two different things. There's overlap, but they're not the same. And when you talk about getting better data on people living alone, I think it's as important to determine, does someone feel lonely? Because that, to me, is the driving factor and what to focus on.
Thank you again for your testimony. Next, we will move on to the presentation on nutritional insecurity. I want to thank you and apologize. When you're the last on the agenda, sometimes your time gets compressed. So if you will just know that we're going to try to end at 10:55 so that we can adjourn on time.
Perfect, great.
When you're ready, please state your name for the record and begin your testimony.
Thank you, Chair Claiborne. My name is Sophie Wallerstedt. I'm the Public Affairs Manager for Second Harvest Heartland, and I will give my colleagues a chance to introduce themselves real quick.
Yep, I'm Karen Spitzfaden. I'm the Public Insights Manager at Second Harvest Heartland.
Thank you, Chair. Peter Whitedock, Government Relations Manager, Hunger Solutions Minnesota, now the advocacy wing of the food group.
Thank you.
Great. And
Please
we'll do our best to be quick so there's time for questions. Thank you for giving us the opportunity to talk today on the current state of senior hunger and food insecurity in Minnesota. Just a quick roadmap. We're going to talk about that. We'll talk about the existing landscape of resources for seniors, and then looking at policy implications, both policy proposals that are coming up now at the legislature and potentially in the future. Second Harvest Heartland is a food bank, one of 6 in Minnesota. We are wholesalers to food shelves and distribute food across our service area and sometimes beyond. We have 423 food shelf partners and over 1,000 program partners, including programs that deliver meals both to seniors and other parts of the community. Last year, we provided nearly 128 million meals to our service area. And while I don't have the data for the other food banks in Minnesota, there's just a little list of those there, including our friends, the food group over in New Hope.
Excellent. So again, Peter with Hunger Solutions and the food group. A little bit about what we do. We're a statewide organization, so we work with over 300 food shelves across the state to make sure that they have the resources that they need to feed their communities. We operate the Minnesota Helpline, so it connects callers to resources like nearby food shelves or feeding programs or assistance with signing up for SNAP. And then we also work on ways to increase access to healthy, culturally connected foods, offering education and support services to hunger relief agencies, to farmers, to community members, and also we advocate at the state and federal level on hunger, ending hunger, advancing sound policy, building grassroots advocacy, and informing and educating the community on hunger in Minnesota.
We wanted to give, in this next section here, just a little bit of an overview of what's been happening. 2023, as you hopefully have heard, an unfortunate news, was our sort of hungriest year on record. Our second largest food shelf, what you'll see that headline, record-breaking month. We had 2 of the highest months ever of food distribution, Second Harvest did, and then we had the sort of record-breaking 7.5 million visits to food shelves in the state. So for everyone, 2023 was a really sort of tough year. And go to the next one. I wanted to sort of connect that to the latest data that we have about seniors and older adults in Minnesota. Unfortunately, the specific data on this is a little outdated. So these numbers are from 2021. And if you pair that with the fact that 2023 was the worst year for everyone, you can imagine that for our seniors and older adults, the problem is even more significant now. And we will be getting slightly updated from 2022 numbers pretty soon here. But for now, we can give you the 2021 estimates that are older adults, so that's ages 50 to 59, our food insecurity rate in Minnesota is 5.3%. That's about 41,500 adults who are age 50 to 59. And then the senior, so age 60 plus, food insecurity rate in Minnesota in 2021, again, let's assume that's higher, but then was 3.8%. That's a little over 47,000 Minnesotans. So in total, in 2021, close to 100,000 adults experiencing food insecurity, and that means like being unable to have enough food for their next meal. There's some, of course, exacerbating factors. We know these are sort of national statistics, but we know that it's also probably true here in Minnesota. This is worse for senior and older adults who are Black. They're almost 4 times more likely, and Latino almost 3 times more likely. We know this is also worse for seniors and older adults who have a disability. Again, it's like 2 times as bad for seniors, 3 times for older adults. And we also know that, as others before me this morning have mentioned, food insecure seniors and older adults are more likely to have chronic health conditions and limitations in their daily activities, and it's sort of all compounding together. And we actually also know when we think about multi-generational households, which you are seeing sort of happen more, those households, the older adults and seniors in those households experience food insecurity at elevated rates because often they're willing to forego food to provide for the younger people in the household. So there are programs in the state that exist to help with these problems. We won't cover all of them. Of course, there's a few key state programs that I haven't listed here, but the 3 largest, Lutheran Social Service runs Meals on Wheels, which is the largest provider of senior nutrition in the state. There's, of course, SNAP, which we know has different rules and eligibility for seniors. The current minimum benefit level is $23 a month. We'll get to that in a second. And then the CSFP program administered statewide, but a national program, federal program, provides 1 box of shelf-stable food per month. The other sort of resources available for seniors in the state include kind of the senior nutrition program, the farmers market program that's available in the summer months, and then the sort of generally food shelves like Second Harvest, food shelves that Second Harvest sort of distributes to, and also food shelves throughout the community, different communities. I'll do a little brief overview. CSFP, the commodity food program, is the Second Harvest. That's our biggest direct-to-neighbor program, and it's the biggest way that we serve seniors. To be eligible, you have to be 60 or older and your income at or below 130% of the federal poverty level. Second Harvest Heartland serves 5,000 seniors a month. There's 230 distribution sites in our counties. You'll see that map, though. There are more across the state. Yes.
So when we talk about 130% of federal poverty level,
Yep.
most people have no clue as to what that is. Do you have a dollar number for that?
I don't have it off the top of my head. I do have it in another thing I could sort of give it
Perfect.
to you.
Thank
Yes.
you.
Yep. And I'll say the key thing about this program, it's a box of food, and usually you have to pick it up. Second Harvest is currently working on a sort of relatively small scale. We've got a small partnership with DoorDash to try to get to deliveries, because we know that sort of getting to the distribution site is often difficult for seniors and older adults. But that's, like I said, a small program, and the first time you get a box of food can't be delivery, so we do have to, people have to go. So we've got a picture here on the left side of what's often in a box. So it's shelf-stable food, it's pre-packed, it's all of those things in a 2-pound block of American cheese. So it's like canned fruits and vegetables, juice, shelf-stable milk, some canned protein, things like that. And I think that's relevant to the kind of trends we've been seeing in this program. So since kind of 2020, we've seen a steady decrease in the number of people using it. Pre-pandemic, we were serving around 9,000 seniors a month. Now we're really seeing only about 5,000. We think this is kind of for 3 primary reasons. It's been really difficult to do outreach to people who've aged into being eligible for this program since the pandemic. There are fewer dollars available for outreach, and also we used to do it kind of in the community to see people, and that people are just sort of out a lot less. Secondly, people, as I mentioned, are a little less likely to leave their homes, so we do think food delivery is a really important situation going forward. And then thirdly, most sort of specifically for this program, this food is often not very culturally relevant, and as we see sort of the seniors in our state being from different sort of cultural backgrounds, we're hearing a lot at our distribution sites from people who are kind of choosing not to take a box because it's not food that they eat. So we want to sort of think about that going forward.
Great. Yeah, and so we'll talk a little bit about some policy solutions, and we'll start with a proposal that Hunger Solutions is leading on this year.
Yeah, so this is one state policy solution that would make a big impact on addressing hunger for seniors. And this would be increasing the minimum benefit level on SNAP, which was mentioned at $23 a month is really not enough to put food on the table. And with the loss of the SNAP emergency allotments this last year in the spring, more than 235,000 Minnesota households suffered cuts to their monthly SNAP benefits. On average, that was about $82 a month, but the steepest cliff was for those who were at that minimum level. And so many older adults saw that their benefits dropped from 280 back down to 23. So a significant hit to someone's food budget led to many people having to turn to their local food shelf for help, which we know food shelves alone cannot fill that gap, as was mentioned earlier with the increase in visits that they're experiencing right now. So we, along with many partners here, are advocating for increasing that current federal benefit from $23 up to $50 for those seniors who are 55 and older, with the state's help to supplement that additional amount. And we didn't have bill numbers at the time, but now it's House File 4108, Senate File 4146. So this would basically help create a safety net for those who are struggling, many vulnerable seniors who rely on nutritious foods to keep them healthy, also food retailers who saw a significant decrease in their business as a result of the ending of SNAP emergency allotments, and basically reduce food insecurity for thousands of Minnesotans in desperate need of help. So again, this would be one policy solution to tackle the issue of hunger for seniors.
And we have two more proposals that are up during this legislative session. I'll focus mostly on the SNAP Restaurant Meals Program. This is a bill that's being led by Ramsey County. There is a federal restaurant meals program that a state can opt into to allow people that may not be able to cook food at home, either due to age or disability, illness, and they would be able, if they're already eligible for SNAP, be able to use their SNAP to buy prepared hot meals at a current EBT vendor. It says restaurant meals, it's more geared towards grocery stores. If you think about the idea that you can buy a cold rotisserie chicken at the grocery store, but you can't buy a hot one with your SNAP benefits. And so just focusing on that. And then lastly, and this is more broad to the situation of food insecurity in general in the state right now, but we are looking at the establishment of a Minnesota Food Bank program that would be a direct injection of food into the system by providing funding to the food banks across the state to buy food to distribute to food shelves for free. And then lastly, looking at future considerations. So thinking about how do we expand support for those rural communities, which we know are aging faster and are more difficult to serve. Thinking to more about funding for that delivery of groceries or meals, especially for older adults. And as Karen said, looking at access to more culturally relevant food, including in those CSFP boxes, and as the prepared meals bill, similar increased support for prepared food. That's it. How'd we do? Pretty great.
I want to thank you for being on time and a great presentation. Members, do you have any questions? Thank you very much for your presentation. And in all fairness, I said to other groups they couldn't talk about current legislation, so I gave you a little bit of room there. So, thank you. All right. One of the things I want to talk to our membership about, how do we want to fit these important, we haven't yet heard from the business side of aging, so we haven't really talked about employment and older adults in the workforce, and many areas of financial security that we heard about today on the left side of the chart that Ms. Camp talked to us about. So we need to think about how we want to fit those conversations into our work as well, because older adults who want to stay relevant in the workplace, what kind of accommodations could we recommend? What kind of job sharing? What would that look like? And maybe we want to hear from those business sectors. So we need to think about that as we're shifting our discussion to recommendations. And then always as we are thinking about these conversations, it's about birth to, I forget how you described it. Someone described it in a wonderful way, the end of life. How do we create a healthy aging ecosystem for Minnesotans, right? And that's what we really want to think about as we go forward. Our next meeting is Mr. George.
Thank you, Chair Cleaborn. Our next meeting, I believe, it's that second Friday. in April. It'll be in Capitol 120. It'll be, let's see, Friday, April 12th at 9 a.m. in Capitol 120.
So that'll be upstairs, one floor, and it's a bigger conference room. Dr. Gugler, did you want to say something? I always watch you move. I watch your body language.
Very excited. So,
Okay.
well, I'll say one. Well, you called on me. It's
Yes,
your
of
fault,
course.
so. I mean, one thing I thought the first part of the meeting today was great. I felt like we started taking steps toward the substantive activity of why we were convened, I believe. And I hope, and hopefully the other task force members agree, that we continue carving out that time and space in upcoming meetings, if not making it the majority of our meeting time. As you had indicated, we have a lot of work. We're probably going to have to put subcommittees together. And so we probably have to think, in addition to the organization, to the process of, we likely are going to have to identify other resources to pull and synthesize a lot of this information, unless task force members are willing to do it. And I have to admit, I can't say I am, so.
Dr. Gugler, please. No, it is important work. And so what I need to know, if you'll send, task force members, if you'll send to Mr. George your priority area, whatever specific interest you might have based on the conversations that we've had. And then we can think about convening smaller ad hoc work groups, whether they are members of the public, and we have those meetings, let the public come and then present what their ad hoc work group has come up with for suggestions, or if it's with task force members, we can work that out. But please just send to Mr. George, Andrew George, your suggestions, and you can find his contact information at the Legislative Coordinating Commission Task Force. Oh, Maureen, did you have a comment you wanted to make?
Yes, thank you, Madam Chair. I'll be quick. Thinking about future testifiers or presentations, I do want to mention again that with so many of our Minnesota elders being served within their health care by Medicare Advantage plans, I really do believe that the managed care organizations in the state would be able to provide us with some interesting background on the enrollees that they serve. And I'm hoping at some point in time, whether through general testimony or as part of an ad hoc subcommittee, that we are able to hear from the managed care folks. Thank you, Madam Chair, and for a great meeting.
Thank you very much for that recommendation. I don't see any more hands up from the task force. So with our work for today concluded, I did want to give, Mr. George, why don't you give your Legislative Coordinating Commission email address, and then.
Certainly, if members want to reach out to me for this, these subcommittees and thoughts on topics, and members of the public as well, my email is andrew.george@lcc.mn.gov, and that information can also be found on the task force website.
Thank you, Mr. George. And with our work concluded for the day, we are adjourned.